Hello, your mic is off.
Okay, sorry. So, good evening and salam alaikum to everyone.
Well,
And thank you so much so far who has joined. I am seeing like 9, 10
10,
people has joined so
15.
far.
Okay, within 4 or 5 minutes, I think.
Yeah,
Who are the presenters except me? I don't know who are others.
I think as the time is like 7 Pakistan time and everyone according to their time, I think we'll be
Yeah.
waiting for the sharp tick of the clock. And so we'll be joined. And I would like to welcome Dr. Saroj Choramani. Thank you, Dr. Saroj. And
Hello,
welcome
nice
to the
to
FAPSS
meet you.
webinars.
Thank you, Madam Zafri.
Nabila. I am Nabila Talat.
Yeah, Dr. Nadila Talat.
Yeah.
I'm not able to see you on your video.
Can you see my video?
I'm able
Hello.
to
Ravi,
see
On my video.
Dr. Talat. Navina
Ravi,
Talat.
your video is not on yet.
I don't know what's wrong. I'm trying.
Can't you see the video icon at the left lower corner?
Saroj ma'am, namaste.
Hello, namaskar. Welcome.
Namaste from Nepal.
Dr. Chaudhary. Yes, I can see you on your face now. Lovely.
Yeah, thank you. So I met you in 2008 with Professor Gupta in AIMS.
Okay, long ago.
Great.
And
Okay.
we had a party in the evening.
That's good.
Hello?
Good. It's nice, Dr. Pakran. Very nice to see you.
Yeah.
Almost
So,
14 years now.
yeah, almost 14 years.
Yeah. Good. So,
So our,
in which institution are you at Nepal? Are you in practice
yeah,
or are you in teaching institution?
yes, I work in Tribhuvan University Teaching Hospital, Kathmandu.
Okay, that's lovely. I believe it's a very good institution.
Yeah, one of the pioneer institution of Nepal.
Yeah.
Yeah.
I understand in the beginning of it, you had good collaboration with AIMS for the establishment of the institution.
Yeah. So that was in actually the AIMS was supported to the Dharan Institute, BP Koirala Institute of Health Sciences.
Okay, BP Kerala. Okay.
Yeah, that is in Dharan in eastern part of Nepal. But
Okay.
I work in Kathmandu.
You are working in Kathmandu.
Ravi, now your video
Can I
is.
see?
Now Saudari
I'm
is
trying
here.
to stop it. I'm trying. I don't know something like that. Hello, how are you? Good evening, everyone.
Good
Hello.
evening.
Good evening. And welcome to the webinar.
Good to see you again.
Same. I think
Tanur, how are
it's a
you?
good activity and virtual meeting is
How
like
are you?
good.
Good evening.
Definitely. It's good to get connected through webinar.
Yeah.
Dr.
So how
Nabila,
are
where
you,
are
ma'am?
you working in Pakistan?
Dr. Saroj, I am working at the Children's Hospital, Lahore, which is
Lahore.
like granted the status of university 2 years back. And now we are
Okay.
University of Child Health Sciences.
Very good. Very nice. Very
Yes.
good. That's
It's
very
like All India Institute of Medical Sciences. We are dedicated tertiary care pediatric setup with around 45 pediatric specialties of medicine, surgery, and diagnostic under one roof.
Oh, great. That's very great. And
Thank
how
you.
many beds are there in your institution?
We are 1400 bedded. But all the time, almost we are twice or thrice the occupancy because we have no refusal policy and we are public sector. So from every nook and corner of Pakistan, we receive patients.
It's very good.
So how many patients you have present in pediatric surgery?
Dr. Prasad, we are 250 plus bedded, 2 pediatric surgical units with a dedicated surgical ICU of 50 bedded
Wow,
and dedicated surgical nursery of 50 bedded.
Wow.
that's good. That's a great number. How are you,
And
madam?
we are having 11 pediatric surgical super and subspecialties along with the pediatric surgery, including the neonatal cardiac surgery and pediatric neuro, pediatric ortho, pediatric plastic, like all. We are total in 12 pediatric surgery and allied pediatric surgical specialties.
Right.
That's really good.
That's great number.
Thank you.
Good night, everybody.
Thank
I'm
you,
from
Dr.
Hi,
Bangladesh.
Nabila.
Kamral.
How are
Hi,
you,
Kamral.
We
Ramnandar?
say good night at the
Eh,
end of the webinar.
Oh,
Right now, we
good,
can
good
talk
evening.
about good night.
Good evening.
Good evening, still.
Good evening. Good
Good
evening.
evening. Good evening. Eh,
And just
How are you all?
pardon me for a second to close the door.
How are you, Dr. Saroj?
I'm fine. And it's such a delight to be in this meeting.
Thank you, ma'am. You are most
Oh,
welcome. Actually,
thank you.
I've come for our third festival. I'm in Janakpur. I'm not in Kathmandu, so I'm having technical problems. Finally, I'm able to get connected.
We are
Thank
happy
you,
that
Ravi.
you were able to join. Thank you.
Yeah, that's good.
Thank you. I think it's 7:01 and
Yes.
keeping the time constraints of all the cases to cover up in this 1 hour or 15-minute maximum, we will try to wind it up within 1 hour so that everyone remains comfortable at shouldn't be feeling like overburdened because it's the weekdays. And if Dr. Ramandan allow, should I start?
Yes, yes, ma'am. Definitely. Why should we delay? Let's start on time,
Okay.
please.
Thank you so much. So, Bismillahirrahmanirrahim. Assalamu alaikum formally and good evening from Lahore, Pakistan, and from the platform of Federation of Association of Pediatric Surgeons of SAARC. I formally welcome you all, and I'm delighted to share that this is the second webinar of the series, and this has provided opportunity to all the SAARC countries, pediatric surgeons, to share their experiences, or even if they are facing any challenging case, to get input from all the experts of the SAARC countries. And we are open to all the faculty members and pediatric surgery colleagues from across the globe even. So today we have 4 cases, and the 4th case from Chittagong, Bangladesh is not although related to the topic assigned for this webinar, but we are looking forward to a very interesting case because it is related to the current topic, that is AI. So the first case is from the Dhaka, Bangladesh, and Dr. Fahmida Ali is going to present a case over nephroblastoma. Can I have Dr. Fahmida Ali from Dhaka, Bangladesh?
Hey, just talk with her. Just talk with her. She's just connecting to us.
Okay, so
I just talked to her.
okay,
Could you-
so if she is still connecting, we will let her present the next, and we move to the next case. May I ask Dr. Asfa Shaukat from Karachi, Pakistan, to present her
No
case of
problem.
unusual
Yes,
DSP?
yes, yes. Yes.
Dr. Asfa Shaukat. Dr. Asfa, are you on board? Dr. Asfa Shaukat.
We have to move to next then.
Yeah. Okay. So I have made Dr. Nawaz Sharif co-host, and Dr. Nawaz Sharif from Kabul, Afghanistan, is going to present his case regarding Mullerian duct anomalies. And We have Professor Tariq Rahimi from Kabul, Afghanistan as our executive member as well on the platform of FAPSS. So Dr. Nawaz, you can share your screen and start.
Dr. Nawaz. Okay.
You are co-host, Dr. Nawaz.
Yes.
Thank you. We can see your screen. Dr. Nawaz, can you hear us? Dr. Nawaz?
Hello.
Dr. Nawaz, we can't hear you.
Probably his network is giving him trouble.
Technology can ditch anytime.
That's true.
See, it's also in the process of evolution.
Yeah. And we are also in the process of learning how to tackle these issues.
This is.
I'm seeing Dr. Asifa Shaukat. Okay, so he's able to move. Dr. Nawaz, kindly speak so that we can. If Professor Tariq Rahimi is here along, can I request him to contact Dr. Nawaz Sharif?
Okay, I will contact with him in 1 minute.
Okay. So meanwhile, I request Dr. Asifa Shaukat that she can present her case.
Good evening. Sure, ma'am.
Thank you. And I'll make you co-host. Let me. Okay, so Asfa, I have made you co-host. Just try to share screen. I am not sure that you will be able because Dr. Nawaz is still sharing his screen. Okay, good. So kindly share your screen.
Okay.
Walaikum assalam. Thank you. Please start.
Okay, so I'm going to present a case series about DSD. My name is Dr. Asfa Shaukat. I'm from Aga Khan University, working as a pediatric surgery resident. So,
May I request participants to kindly mute their mics other than the presenter?
should I continue?
Yeah, sure.
Okay. So, first case is about the second sibling. Basically, this is about 3 siblings that were raised as females, aged as 8, 6, and 3 years old. So I'm going to proceed with the second one, who is 6 years old. So 6 years old female patient presented to clinic with history of bilateral inguinal swelling that were managed as hernia. The local surgeons raised a suspicion of gonads. On ultrasound, there were no Mullerian structures, bilateral undescended testes and inguinal canal, and there were labioscrotal folds. Patients were referred to Bahawalpur for further investigation. Karyotyping was done, which showed 46XY. Pediatrician advised to rear both children as boys and asked them to start injection testosterone, but the parents deferred it. So, meanwhile, parents started noticing unilateral swelling in the labia majora of the elder one as well. So, they raised the suspicion of the same thing in the elder kid as well. Okay, about past history, both of them, all of 3 of them, born as a consanguineous marriage, no history of maternal fertilization, no history of drug during pregnancy, no significant developmental or past medical history. On examination, baby was well thriving, vitally stable, normotensive, female-like genitalia with moderate clitoromegaly, small introitus with 2 openings. Gonads were palpable bilaterally in the inguinal canal. They were graded as the Prader 2, EMS score was 2. On systemic examination, it was unremarkable, there was no hyperpigmentation. Further investigation was done, prolonged SCG stimulation test, I'll show the result later on, and genetic testing was done, which showed CYP17A1 mutation. So patient diagnosed with 17-alpha hydroxylase deficiency. Here you can see lab reports of the patient, prolonged SCG stimulation test. So basically, testosterone levels were less than the normal range. Androestradiol was also less than the normal range. Dihydrotestosterone was more than the normal range, and the ratio between the testosterone and DHT was less than normal. So we made diagnosis as congenital adrenal hyperplasia, secondary to CYP17A1 mutation. We proceeded with MDT. So parents were counseled about the nature of illness, its outcomes, and decision regarding sex of rearing. They were counseled about the infertility if they're going to raise both as male or female. Requirement of estrogen, testosterone at puberty for development of secondary sexual characteristics. Surgical procedure will be required for either decision, whether it's male or female. Pediatric endocrinology, psychological support team, all were kept on board along with pediatric surgery team. They were counseled about the post-surgical outcomes along with long-term follow-up requirement. So parents decided to continue raising their children as female. We proceeded with the operation of 2 siblings, and one is awaited because of the financial constraints. Before procedure, pre-op workup was done, which showed normal electrolytes, cortisol, ACTH, renin, and aldosterone levels. Procedure was performed on May 2023. It was bilateral orchidectomy, cystoscopy, clitoral reduction, along with vaginoplasty. Intraoperative findings were normal bladder and urethral openings. Separate vaginal and urethral openings, short introitus of 3 cm, blind ending vagina, there was no cervix, and bilateral normal testes. So this baby is being followed on outpatient basis with both pediatric surgery team, endocrinology team, psychosocial team, and they are doing well. Okay, now about the elder kid that I'm going to present at the case number 2. So this is an 8-year-old female kid, raised as female basically, brought to OPD with unilateral inguinal swelling with same suspicion as the second sibling. No significant past medical or developmental history was present. On examination, no clinical abnormality, hyperpigmentation was not present. Patient was thriving well, doing well genitalia on examination. It was female looking, along with clitoromegaly, separate urethral and vaginal opening were present. Partially fused labioscrotal folds were present, right-sided testes and inguinal canal, left testes was in the left labioscrotal fold. And it was staged as predatory. These were the pictures of the kid taken after the permission of parents. As you can see, enlarged labioscrotal folds and enlarged clitoris. Investigations were done. Electrolytes were within normal limits. Karyotyping was done, which was 46x5. Genetic testing was it came as CYP17A1 mutation. So the definitive diagnosis was 17 alpha hydroxylase deficiency. Ultrasound was done, which showed there was no uterus, only lower part of vagina was visualized. Both testes were present in the inguinal canal. Again, we proceeded with the procedure cystoscopy, bilateral orchidectomy, just after the one of the previous case. Intraoperative findings were separate urethral and vaginal openings, a small vaginal opening placed anteriorly clitoromegaly, and bilateral palpable testes. Follow-up is doing, patient is being followed in OPD as well. Patient is doing okay with all teams. So the point of discussion from my side is disorders of sexual development requires both thorough biochemical and genetic testing to make definitive diagnosis. Involvement of MDT, like involvement of pediatric surgery team, pediatric endocrinology, psychological support team is necessary. Detailed discussion with parents and patients themselves should be done about the phenotypic upbringing, and the mutual decision of all before proceeding for any intervention. And they are required for long-term follow-up, whether they develop hypertension or any other abnormality. And third kid is awaited because of their financial status. We'll proceed with her as well soon. Thank you.
Thank you so much, Dr. Asma, for sharing these two consecutive cases of the siblings. And from today's expert panel, first of all, I request the President FAPSS, Professor Ramandan Prasad Chaudhary, to comment upon this case.
Okay, thank you very much. First of all, congratulations for excellent presentation as well as interesting case. And as both are siblings and I have more or less same presentation, that's a very good example as well for the residents, so that they will learn out of it how to manage this case. And as they have done, they have nicely presented and nicely dealt the case as it should have been. So that's a very good example of I know it's difficult. DST management is very difficult in our part of the world, because I don't know the situation in Pakistan, but in Nepal, sometimes there is some legal issues at the latter part of their life, like why we are not taken into account of doing such surgeries. So we have a third gender society, Blue Diamond Society is there in Nepal, and they are creating a little bit some legal issues on cases like this.
Thank you. And now I request Professor Dr. Churamani Gopal. She is very senior consultant, and I request her to comment upon this case from her point of view.
Thank you, Dr.
Nabila.
Nabila.
Yeah.
I think one thing is very interesting, that this three siblings that have almost the same kind of problem. And she did emphasize in her history taking that they are product of consanguineous marriage. Is that true? So one lesson that one would be able to take is that marriages, consanguineous marriages should be avoided as far as possible. That is a preventive aspect, and I think she has very well presented. And converting such disorders into female is technically easier, and converting them into male is more difficult. So the easy path has been taken already. And as far as their function of fertility is concerned, both whether they are raised as male or female, often in the female, since they do not have the internal genitalia, the pregnancy issue or fertility issue never comes up. So is true about male as well. So I would say compliment her and congratulate her to have presented these cases very well. Thank you.
Thank you so much. So, Dr. Asfa, a few comments and questions in the chat box. I would like you to respond. I am sharing that, can we call the swelling as testis or gonads? So, your take on this statement.
Yes, we call it gonads. Like obviously, then we need to make sure whether it's testes or not. Which could be done after karyotyping and on perioperative findings.
And they are asking, Dr. Sarita is asking that histopathology of gonads done or not, and if done, any comment regarding the histopathology. Dr. Asfa?
Oh, yes, I'm here.
Histopathology
yes,
of
it
the
was done.
gonads, gonadal tissue was done or not, and what was it if done?
Yes, it was done. It was testes.
Okay. So another comment.
Dr. Asfa,
Sir, please.
Yes.
I welcome Professor Mohammad Salim, a very senior pediatric surgeon from Lahore, Pakistan. And sir, please.
Dr. Asfa, although I have a weak connection at this time and losing the connection again and again, I could not understand your case. But the second case is the genotype was XY. What was the basis of converting them to female in this case? Why not the option of male reconstruction considered in this case?
Okay, so we planned an MDD for both of these cases, and we took parents and all teams on board, surgeons, endocrinologists, and psychosocial team, and it was decided mutually to proceed with the female rearing of the kid, because both are going to be infertile anyway. And second thing is, at least they can have a better quality of life. That's why we proceeded with female after the parents' consent. So that's why.
What was your final diagnosis? Is the testicular feminization syndrome complete variant or incomplete variant? 5-alpha reductase deficiency or disorder of sexual dysgenetic testes? What was your final diagnosis?
Dr. Asfa, can you hear us? Or
I think Principal also wants to answer, I think.
So the diagnosis was 17-alpha hydroxylase deficiency. So testes were there, but they were not able to work properly because of the deficiency.
What was the deficiency? Receptor deficiency or hormone production deficiency? Or 5-alpha reductase deficiency? What was the actual cause of? Have you tried to reach the final diagnosis?
Yes, it was 17.
This is Dr. Salman Kirmani. I'm sorry, I'm interrupting. I'm the geneticist and the pediatric endocrinologist on the case. So the diagnosis is 17-alpha hydroxylase. Assalamu alaikum. The diagnosis is 17-alpha hydroxylase deficiency, which is a proximal form of congenital adrenal hyperplasia. So it's a disorder of steroidogenesis. It's an enzyme defect which leads to androgen deficiency in XY individuals, and that's why this patient presented like this. So the diagnosis is very clear, proved by molecular testing.
Okay, thank you, Dr. Salman, for your input.
Doctor, actually, scenario changed after 2000. Before 2000, it was common decision that every patient who cannot be reconstructed properly as a male should be converted to female. But afterwards, the scenario changed. There are so many cases which brought the
Sir, we can't hear you, Dr. Salim.
male.
There is distortion.
Moreover, what?
I request Dr. Asfa and Dr. Salman that there are many questions related to endocrinology and surgical reconstruction. Kindly address them in the chat box. And I would like to ask Dr. Asfa to stop sharing her screen. And I would like to ask Dr. Fahmida Ali from Dhaka, Bangladesh to start sharing her screen to proceed for the next case. And I appreciate the input of all the experts, including the input from Professor Dr. Muhammad Salim. And I'll request Dr. Asfa and our seniors to address the concerns in the chat box. Dr. Fahmida, kindly share your screen. I have made you the co-host.
Thank you.
Thank you. Meanwhile, I request all other participants to kindly keep their mics mute and can communicate through the chat box.
Assalamu alaikum.
Wa alaikum assalam. Please go ahead, Dr. Fahmida.
Welcome to this presentation. My presentation is nephroblastoma in a younger female. And my representative is Professor Mirza Kamrul Jahid. He's the head of the Department of Pediatric Surgery, so it's at the Medical College. Alifa, 4 years, 3-month-old female girl, admitted to our hospital at 3rd September 2023 with the complaint of a mass in left loin for 20 days, fever for 7 days. She was well 20 days back, then she noticed a mass in her left loin, which was rapidly increasing in size, also complained of fever for the last 7 days, which was low-grade, intermittent in nature and not associated with chills and rigors, and was subsided by taking antipyretic drugs. The child had no bowel or bladder abnormality, no history of hematuria, not exposed to any offending drug or exposure to radiation. With this complaint, the child was initially treated by a local doctor, then referred to our hospital. He has not significant past illness, immunized according to EPI schedule. She was delivered with lower uterine cesarean section and postnatal period was uneventful. She was exclusive breastfeeding. Is the first issue of her continuous parents. Other family members are healthy. His father is a school teacher. They live in a Paka house, use safe drinking water and maintain proper sanitation. She was normal in appearance and anemia that was present and jaundice and other general examination findings that were absent. There was no lymphadenopathy and she was vitals within her normal limits. We done systemic examination, abdomen that was distended with centrally placed inverted umbilicus. There was a lump involving the left hypochondria, lumbar and umbilical region measuring about 10 into 8 centimeter, which was rounded, smooth, firm in consistency, free from overlying skin and fixed to underlying structure. The lungs didn't move with respiration and didn't cross the midline. Upper border of the liver dullness that was present in the right fifth intercostal space, and there was no free till and shifting dullness. Bowel sound that was present, and digital rectal examination revealed no abnormality. Other systemic examination that was normal. Alifa, 4-year, 3-month-old child, second issue of a non-consanguineous couple, presented with left-sided rapidly increasing glowing mass for 20 days and low-grade intermittent fever for 7 days. She was ill-looking, irritable, having 15 kg weight, anemic. Temperature was 100 degree Fahrenheit. Body temperature, blood pressure 90 and 60. A rounded mass measuring 10 into 8 centimeter, involving right hypochondriac and lumbar region that was rounded, firm, smooth, free from overlying skin and fixed with underlying structure. Swelling either moved with respiration nor crossed the midline. The left kidney was palpable. No history of hematuria, bowel and bladder abnormalities, and other systemic examination was normal. So initially, our provisional diagnosis was left-sided nephroblastoma. After that, I have some differentiation diagnosis that was neuroblastoma and hydronephrosis. We done some hematological, biochemical, and imaging, and all the hematological and biochemical investigation are within normal limits. And ultrasonography of the whole abdomen that was revealed that left kidney grossly enlarged in size and grossly distorted renal architecture. Due to presence of a large solid mass that occupies the pelvic calcareous system, the size of the mass that is about 10 into 8.8 into 8 into 8.6 centimeter. Numerous hypoechogenic peaks are seen within it. Right kidney that was normal size, shape, and texture. Other organs are normal, and they comment that that was the left renal mass nephroblastoma. We done CT scan of abdomen that suggests nephroblastoma in the left renal region. That is the film of CT scan. And our preoperative diagnosis that was nephroblastoma over the left side. After admission to the ward, we managed the patient with normal diet, intravenous antibiotic, and preoperative blood transfusion, and then we prepared the patient for surgery by taking written informed consent and proper counseling. We did the operation 14 September 2023, left ureteronephrectomy under general anesthesia. We opened the abdomen through supraumbilical transverse incision. A large firm mass which involving the left kidney we found, and the right kidney and lymph node appeared normal. Left ureter renal vessels were identified and ligated with 30 round body vicryl, and then left-sided ureteronephrectomy was done. Hemostasis secured, then a 14-FR drain tube we kept in C2, and after that we closed the wound and specimen sent for histopathological examination. Our postoperative diagnosis after the changes, nephroblastoma, left-sided stage 2. Postoperatively, we managed the patient, nothing per mouth for 24 hours, IV fluid and broad-spectrum antibiotics along with analgesia and proton pump inhibitor. Postoperative period that was uneventful. We started feeding on first POD, drain removed second POD, and dressing checked on fourth POD, and OD found healthy. We transferred the patient to pediatric hemato-oncology department on HPLG, and we found the histopathology report at that main time that was Wilms tumor favorable histopathology. And after that, my final diagnosis was left-sided Wilms tumor stage 2. Thank you everyone for having the presentation.
Okay, thank you, Dr. Fahmida, for sharing a very commonly encountered to all pediatric surgeons and pediatric surgical oncologists and pediatric urologists dealing the case. Wilms is commonly dealt by all these specialists, and there is overlapping. and everyone has experience. So keeping that in mind, I would like to ask Dr. Mirza Kamrul Zahid to first share his concern or any queries or any challenges he see in the long term for this particular case, as you people have shared with us. And then I would request the expert panel to give their input. Dr. Kamrul Zahid, can you please share?
Thank you. Thank you to all. This patient, we have no tumor board, but we have pediatric radio oncologist. We discussed with radio oncologist prior to our surgical decision. Then we operated the patient, and further then we operated the patient and referred the patient to the oncologist. But and we have expert anesthetist and other supporting staffs. So we have no problem in the surgical management at all.
Okay, thank you. So may I request Professor Dr. Mohammad Arshad from Karachi, Pakistan, to share his experience and give his input over this case.
Yeah, thank you very much, Dr. Famida, for presenting this case, and Dr. in my opinion. I think what you are following is basically the of you're following the technology group recommendation where the surgery is done as a first, and then depending upon the histopathology, you decide about chemotherapy. Both approaches have similar outcome, and we have seen in the both use nowadays we POP, that where initial chemotherapy is given, then the surgery is performed. I think for important point is, especially for resident to know what managing your role is. First is that to resect the tumor without, and also document the finding at time of surgery, and take the specimen of lymph nodes appropriately para-cable, and so and minimum of 15 to 20 nodes used to be sampled to have exact histopathology, and also documented if there was any breach to the tumor, because that was to for about
Thank you, sir. And may I ask Dr. Churamani again, request her to give her experience-based input over this case. And I welcome Dr. Shilpa Sharma. Thank you, Shilpa. And I hope you are in Chittagong right now.
Yeah, I just came back with Wi-Fi.
Okay, I know you are busy there, but still sparing time. Thank you for joining. Okay.
Welcome, Shilpa. Welcome, Shilpa, to Bangladesh.
Thank you for joining.
From Bangladesh, she has joined. That's great.
Yeah. Okay.
Thank you.
Good evening, Shilpa.
Thank you, Dr. Nabila. I think there is every institution nowadays first decides their own policies, or because one would like to either follow national anti and or one would like to follow European, or nowadays it has been all mixed up with COG, Children Oncology Group. So policies could be first decided. However, in this particular case, since it was not a huge mass, surgical excision was a right procedure. Only thing was that she could emphasize if she saw any lymph nodes, and if they were, biopsy of those lymph nodes should be taken and should be corroborated, because it has been seen that when these lymph nodes are positive, it makes a difference in their recurrence rate and ultimate mortality rate as well. Otherwise, if the lymph nodes are negative, then this case with a favorable histology will go to a low risk group where the chemotherapy desired is also not long term. 6 weeks to 12 weeks chemotherapy should be good enough, and radiotherapy may not be needed. So it would have been nice if she could have elaborated the further management, what was decided in their own setup with the oncologist group. Thank you so much for presenting this great event.
Thank you so much, madam. Dr. Fahmida, would you like to answer these concerns raised by Professor Dr. Churamani, as well as few concerns in the chat box? I would request you to address them there. And now I request Dr. Nawaz Sharif to kindly start sharing his screen and present his case.
Salam. Am I audible?
Yeah.
Yes.
Salam to all. I'm so happy to be with you. So, dear audience, as you can see in this view, this is a view of our hospital, French Medical Institute for Mother and Children, or FAPSS, which is located in Kabul. Our hospital have 170 beds, including different departments. Beside of this, we have residency program or postgraduate program in several departments. I'm the first year resident in pediatric surgery under the leading of our dear professor, Dr. Tariq Rahimi. I would like to present a case about Mullerian duct anomalies. First, I will look to the introduction. Mullerian duct anomalies are those structural anomalies caused in errors in Mullerian duct development during embryonic morphology. Genetic cause of Mullerian duct anomalies are complicated and uncommon. Inheritance pattern can be autosomal dominant, recessive, and X-linked disorder. Mullerian duct anomalies can be part of multiple malformation syndromes. There are many classifications. The recent and utilized classification is the American Society for Reproductive Medicine 2021, in which uterine anomalies are classified into similar group based on developmental failure according to clinical manifestation, treatment, and pregnancy outcome. It's important that diagnosis and treatment options should be chosen carefully by an expert surgeon in a well-equipped pediatric hospital. In many cases, the condition can be left untreated, in particular when it does not significantly affect reproduction. Mullerian anomalies that prevent menstruation or cause significant pain are usually surgically treatment. Investigation, the accurate and highly accepted tool is MRI for the evaluation of Mullerian duct anomalies, and we can also perform ultrasonography, CT scan, and hysterosalpingography. Our case was a 12-year-old girl which was presented to our pediatric clinic by the following complaints: chronic abdominal pain since 3 months, and dysuria, and sometimes fever. The patient past history was which was diagnosed for left side ureteric stone in another center. but the surgeon one failed to find the stone. The blood history was normal. In physical examination, there was normal external genitalia. The investigation was also normal, as you see in the picture. There was no any significant change. The sonographic examination there was the endometrial canal was empty and returns normal signals. Urinary bladder was enlarged and atonic, contains a large amount of air with air fluid level. Both ovaries were normal in size and morphology. Rectum was distended and loaded with fecal material. No enlargement lymph node in the area. No free fluid in the cul-de-sac or cavity of the Douglas. Both kidney were normal in size and morphology and in position. CT reported the bilateral distal ureteric diverticola filled with stone associated with bilateral congenital megareter and atonic urinary bladder. And the MCO reported right side grade 5 vesico-ureterial reflux. MRI reported complex Mullerian duct anomaly with the left side unicoordinate uterus and a separate right side rudimentary uterine horn, which terminate to a blended vaginal furnace. And there was multiple calcification or calculi are seen in both dilatal vaginal furnaces, and that was probable fistula with urinary bladder or distal urine. These are the images of MRI. As you can see, there are a rudimentary horn of the uterus, and you can see multiple calcification in the vaginal furnace. Cystoscopy was also performed for the patient. There was an abnormal opening of vagina. It was at the level of 1 to 2 centimeters below to the bladder neck. And in vagina, there were multiple caliculi or calcification that you can see in the next image. As you see, these are two images from the cystoscopy. These are multiple stone in the vaginal canal. In management plan, we are going to decide about further management and surgery in the upcoming months. And our next plan will be laparoscopy for the patient to determine about the uterus. And we appreciate your comments about the management plan and follow-up. In the last image, you can see this is a part of our pediatric surgery group. Thanks a lot.
Thank you so much, Dr. Nawaz Sharif. And may I ask you that what surgical plan you have in your mind?
Laparoscopy, that we will perform it, and then we will go for vaginoplasty as there is an abnormal opening of vagina.
Okay, so thank you. And Dr. Nawaz Sharif presented from Kabul, Afghanistan. And may I ask Professor Tariq Rahimi, from executive member of FAPSS from Afghanistan, to give his input over this case from his side, and then I would ask the expert panel.
Thank you very much. Actually, some of the CT scan was wrongly reported with ultrasonography, and for this reason, in the other hospital, they did wrong procedure because they tried to find stones in the ureter, but unfortunately there was no stone, and there was not useful surgery. And for now, we have because it's a complex Mullerian duct anomaly, and beside that, it's abnormal vaginal cavity, vaginal opening in the ureter. So actually, it was a new case for us. According to Mullerian duct, in this issue, we will try about the ethical issues, also about to talk with the family, and also about we take decision about laparoscopy. Maybe we can excise one part of the uterus which is not connected, and or maybe the laparoscopy give us more details. As you know, we have faced with a lot of challenges in like our countries, which we were in 40 years in the civil war. Like you see, we our CT scan sometimes reported wrongly, or maybe some CT scan sent to other countries for reporting. In our center, fortunately, we have good radiologists. They have trained outside of the country. Also, we have PGM program. So for this reason, we always try to go slowly, and to do all lab exam for complex surgeries, for difficult cases, to have a good outcome. And up to now, we have not decided about how to do the vaginoplasty, or because we remove some stones by cystoscopy, this procedure, but there is about maybe 15 or 17 hard stones in near to the one side, right side uterus, which is have opening. So for this reason, we ask also, we need your opinion from where we should start after laparoscopic, or in this cause it's also difficult to do salpingography, or maybe with laparoscopy we can do some things. Maybe our expert in this team can give more details about these issues to further that we go with this.
Okay, thank you, Dr. Tariq. And may I request Dr. Ramandan Prasad to give his input over this case and the concerns shared by Dr. Tariq Rahimi in the definitive management of this patient.
Yeah, can you hear me?
Yeah, thank you.
Yes,
please
I think as you said, as you said, it's very good case, and I think the it's a teamwork is definitely important. And somebody in the comments group, they were asking about formation of tumor board, etc. Definitely, formation of tumor board is definitely a multidisciplinary approach. Even before surgery, during surgery, that would be always better. But all institute doesn't have that privilege for having tumor board for the thing. So I think that's fine. It's okay. And regarding that case, like previous speaker has already highlighted about that. So I think it's good to continue that.
Okay, thank you. May I request Professor Arshad, with his experience in dealing, and he has shared another DSC related case today. So kindly give your input in management options you think appropriate for this patient.
So first of all, is that what they're saying is that it's the ureter, Dr. Rahimi, ureter is opening into the vagina. Is that an ectopic ureter you're saying?
Actually, yeah, the vaginal canal has just in the in vagina was not or not normal, and there is only one opening, which is directly go to the bladder. So, but after bladder neck, 1 centimeter distal from this, there is another which is maybe about 45 degree go to the other side, which we went. It was vaginal canal.
So are you dealing with the urogenital sinus then?
Yeah, it's like, for this reason I said it's like two problems. One Mullerian, and this one also.
Yeah, so because it seems like that this is then a urogenital sinus with ectopic ureter opening into the urogenital sinus, right? So was there a history of dribbling of urine before that?
No, the child has continence of urine. The urine is completely okay. He can control his urine. No issue about urine.
Okay, so then this unlikely that this will be an ectopic ureter opening beyond the sphincter, right? So
yeah.
if the beyond the ureter at the bladder sphincter, then you expect some spillage of urine. And do you have any radioisotope scans done for the kidney drainage?
No, unfortunately, we don't have in Afghanistan this exam. But the child has reflux in according to the MCU, grade 5.
Yeah. But does that show a reflux into a ureter which is distally attached, or is a normal position?
Both ureter are normal position.
Right.
In blood.
So then probability of this opening, which you see beyond the bladder neck, is unlikely to be the ureter. So what I suggest is this: when you are doing a cystoscopy, you can pass a small tube into that and put some contrast. And if you have a fluoroscopy, to see what exactly that structure is. And sometime with urogenital sinus, you may have a vaginal opening, which is opening behind the urethral opening. And so first is, so this is the other thing which you have to define. First is to define the anatomy, and then you can define pathology also, that what are the possibilities.
Yes, true. We can do this to do a contrast study with the cystoscope. Yeah, it's a good idea. We can do it.
Yeah, yeah. And then that will give you, sometimes you may have a bifid vagina, and as you're showing that if am I right, you mentioned that you had a bifid uterus, right?
Yes, one of the it's bicornate uterus. One is one was opening in that vaginal canal, which has stones. In the MRI, we can see clearly in the system. And unfortunately, in the system was I wanted to share also the video for you, that the video of MRI. Because the continuity has in this canal, the one right side of the right side bicornate uterus, but the left side is completely small uterus, which is blind.
Right, and her anal opening is at normal position.
Yeah, yeah,
yeah. So
no
this
issue about that full passage, nothing.
So this will be a urogenital sinus, and probably you have two vagina, and one is opening is obstructed, and because the stone formation may be due to stagnant urine, due to reflux of urine into that cavity, and that might explain the formation of.
Well, according to the MRI, that area which has stone, it's open. The uterus in that area.
Okay.
Yeah.
The only thing which can explain form
laparoscopy, we find some issue inside to see by direct vision. And also that point which you mentioned about to do cystoscopy, I think we can have more continuity by pushing small tube or stent inside the opening of uterus. We can have more details and pictures from there. We have fluoroscopy facility in our OT. We can do it.
Yeah, I think we need to follow this case, and I request Professor Tariq Rahimi and Dr. Nawaz Sharif to share an update in next webinar. We will allocate a short time slot for the update regarding this case after performing cystoscopy and laparoscopy as suggested by themselves and endorsed by Dr. Arshad as well. And we will then see that what findings come in and how this case can be offered a definitive management for a good functional life. And I would request Dr. Nawaz Sharif to stop sharing screen. Coming to the last
Thank you for,
case of
I think
today's.
this will be a great platform for sharing of cases. And I actually, our area have same pathologies. We can help more children according to this channel. Thank you.
Yeah, thank you so much. And this was the sole purpose. And I'm like thankful to the FAPSS platform that we all are gathered here. And inshallah, fingers crossed, we will be like keeping it regularly. And now I request Dr. Jafarul Hanan from Chittagong, Bangladesh, to share his screen and share his presentation regarding the use of AR smart glasses. And I think this is the era of technology, and all will be very eagerly waiting to listen to him regarding the experience of this technology in pediatric surgery.
Make me co-host, please.
I have already, Dr. Anna.
I cannot see.
Okay, let me recheck. Okay, kindly share your screen. Taking the opportunity, meanwhile, I am again thankful to everyone who spared time and who joined, and we look forward to regular participation in terms of presentations as well. Dr. Jafar, kindly unmute yourself. And shortly, we will share the Google link for the feedback. I would request every one of you to spare few minutes to fill the feedback form. Yeah, please, Dr. Jafar.
এটা একটু শেয়ার করে দেন বাবা, স্ক্রিনটা শেয়ার করে দেন, এটা ওপেন করি। Share how?
On the bottom bar, there will be a green tab with the share screen upward arrow. Kindly click that, Dr. Jafar Lana.
Okay, I think
it
is okay now.
Started. Yeah, kindly go to slideshow.
Okay. Hi, Shilpa. Welcome to Chittagong.
Thank you so much.
Okay. Thank you for allowing me into your meeting, because my topic is a bit different. So you can see that I am wearing the smart glass. This is not obstructing my views, and here is the battery. So welcome you all to this meeting. And our topic is remote laparoscopy training using augmented reality smart glasses. Someone is talking, so my...
May I request everyone to please keep my mute.
I cannot continue with
We can hear you, Dr. Jafar. We can hear you clearly.
I cannot proceed with my slides. Okay, I think it is okay.
You can forward from yes down arrow.
Okay, now I can do now. So in my this is a program I have started in July, and I am the mentor so far, and I've got 12 mentees or trainees, 7 from Bangladesh and 1 each from Afghanistan, Pakistan, Cuba, Tunisia and Algeria. And our Professor Ashrafullah Kajal and Professor Shadrul Alam are in the program as observers. We all know that mentorship, that is observation of works of experts, is extremely important for acquisition and improvement of surgical skills. We, the surgical practitioners, spend our entire careers learning and perfecting our techniques whenever there is something new. So we are now talking about the laparoscopy. I am working with the laparoscopy training since 2007, principally for the young surgeons from Bangladesh, but few from abroad also came to my place, including our Professor Ramnandan Chaudhary in probably 2009, Ravi. And the scenario of pediatric laparoscopy in Bangladesh is not so good. We can hear from Dr. Samuel Hassan.
I work in Bangladesh Shishu Hospital and Institute. It's the largest pediatric hospital of the country. And we do almost 5,000 pediatric surgical procedures every year. Unfortunately, less than 2% of these procedures are laparoscopic. Because of inadequate training and lack of trained supervision,
So I have started this training in 2007, and you have seen these are from Bangladesh. Many more are there, and Professor Ramnandan Chaudhary, he also came here, one from Switzerland, one from Hungary. We have experienced the corona pandemic, and hands-on training was disrupted during that time. And right now in our country, situation hampers the hands-on training or physical training facilities for many surgeons in Ukraine and other parts of the world. So remote training is a necessity out of these adversities. And I have studied thoroughly about this remote training, and to me the best option is augmented reality smart glasses, and Vuzix is the industry leader. Vuzix M400 I have been using, and Televu is a company from Canada. They are providing the software, and these devices and softwares are donated by Ohana One, which is a NGO in USA, through their surgical site smart glass program. It was a complete donation. From July 4 to November 4 this year, 11 pediatric surgeons joined my program. 8 of them participated at least in 3 sessions, so I have included them in this study. I have conducted a survey among them with 17 questions using 5-point Likert scale, and their responses were graded and analyzed. The questionnaire was created in the form of statements and covered the issues of their immersive experience, quality of videos, quality of training, and whether they will recommend the training program to their peers. This training module works on the principle of remote assistance. Many of you have already heard about this technology, I think. The mentor wears the smart glasses, as you have seen I have been wearing. A device is connected to the laparoscope. That is two devices. One is a smart glass with the surgeon, and another device is connected to the laparoscope machine. Both the devices are connected to the software suite through the Wi-Fi. I then generate a link and share to my mentees. They can click on the link and join the session with me without video. I can hear them, they can hear me. They can see me, but I cannot see them. Mentees can join from anywhere, from their home, their office, or while on the move with their devices, mobile phone, laptop, or tab. This is, I am generating the session. I am sharing the link. The mentee click on the link and join. His or her screen shows like this, and this is me in the operation theater. And these are some pictures taken by the mentees during the session. They can see two screens, one from the glass, the external view, and one from the laparoscope, the internal view. And me, my assistant, and my anesthetist, only two more people is necessary in the, one is nurse and one is ward boy. No more person is necessary for this operative session. Mentees, in fact, see the augmented video. They can see better video than I see. They can ask me questions, they can raise questions, and they make suggestion, which sometimes I listen to. And they can also control from their end my glasses. There are options in their screen. They can zoom in, zoom out, focus, or they can correct the lightings. It's like live operative workshop every day. No extra cameras, no more manpower or other things. So this is a small clip of. See the port placement here, 3 ports. This, in case of smaller children, I would have given here. This here.
And I have a question to ask.
Yeah.
That passport, you put it, for us here in Cuba, we used to put it in the mud bonnet point. That's working.
Oh, no port in the McBurney's point. It is suprapubic. See the port. So this is a small clip of the actual session when it is running. In fact, the session places the mentees virtually into the operation theater. We can hear from one of the mentees what she feels.
This opportunity has provided us to witness surgeries, especially laparoscopic procedures, in real time, allowing us to gain insight and knowledge that textbook or YouTube video cannot provide alone. Believe.
And all the sessions are automatically recorded and saved in the cloud of the Teleview, and we can later see them repeatedly, and I share them with the mentees. They can see repeatedly or analyze. The mentor works hands-free. My hands are totally free into the operation. I am wearing the glass here. On the opposite side is the battery. And unobstructed view, no extra manpower is necessary. Minimum crowd, that is good for prevention of infection. So we have seen the mentee satisfaction score in the survey. Immersive experience, that is real-time presence in the operation theater. There 75% of them are happy. And video from the glass view, that is from the smart glass, 87% said that this is good. Video from the laparoscope, 75%. Regarding acquiring new skills, 85% said that they have learned something new. And usefulness of the training to their work, 88% agreed. Quality of training also 88% satisfied, and 100% are ready to recommend this training program to their friends and colleagues. The take-home message is the short period of hands-on training, given the situation, at least in our country, one junior surgeon cannot spend months for these special types of training or any new thing to go to another place and learn. So someone can go to a mentor or an expert for a few days and then continue with this remote training for a few months. What my trainees are doing, they have spent 15 days with me and now 3 to 4 months with me online, and they can see more cases and they can practice laparotrainer at their home and perfect their hand-eye coordination and suturing knotting skills, and they can get enough confidence to pursue their own careers in laparoscopic surgery. And the next phase of our program is,
If
Samuel says,
I had the glass, I could do this operation with using this glass, and my mentor the operation, and he could guide me from his center. It could increase my number of laparoscopic surgery. It could increase my confidence during doing performing laparoscopy.
So we are planning to provide glasses to at least Dhaka Bangladesh Shishu Hospital and Dhaka Medical College, so that the junior surgeons can wear the glasses and do the operations, and I or any other mentor or expert from remote places can guide them. We are near the ending. Let's hear from our friend Professor Ashraful Kajol. He is the head of the Department of Pediatric Surgery in Dhaka Medical College.
I believe this device will help our young surgeons as well as our trainees, our residents tremendously. Even an old dog can learn a few tricks, and as such, senior surgeons will definitely be benefited by this technology as well. I believe.
So anyone can join us as mentor or mentee, and you can contact us here, hellosearch.org or jafrahanan@gmail.com. Thank you all for joining. Thank you.
Thank you so much, Dr. Jafar, and everyone is appreciating in the chat box your this initiative and an effort to impart the skill and bringing the trainees and the juniors to the world level as the minimal access or minimal invasive is the future. And I would request you to kindly share these links and your email in the chat box as well as there are few queries in the chat box. Kindly address them there. With this, I would again like to thank everyone to spare time and to be with us so far. And our next webinar will be on 22nd February, which is Thursday at same time, that is 7 p.m. Pakistan Standard Time. And the topic will be upper GI. And I would request everyone to bring with cases, and especially like Professor Tariq Rahimi has brought today the challenging case, and still the findings has to come. So this will be good that if other than the success story, yes, the success stories also teach and help us learning, but the challenging case will give more opportunity to discuss and to have input from our experts. I'm thankful to Professor Amandan Prasad, Professor Churamani Gopal, Professor Dr. Muhammad Arshad, and Dr. Binde to give their input as expert panel. I'm thankful to Journal Secretary Dr. Shilpa, who being still busy in Chittagong, spare time and joined. And I am thankful to all the presenters as well. And looking forward to see you again on 22nd February, Thursday, same time with upper GI cases. Thank you so much.
Thank you. And Shilpa asked me if it can be used for live operative workshop with the chairpersons as intermediaries between mentor and audience. Yes, I can connect 6 mentees with me. I am the mentor and 6 persons can join me in a single session with this technology. So chairperson on anybody, I can send link. Before that, I can send links for sign up. You have to sign up first. Then when I send the link, you can join my session whenever I share that. And it is a
maybe when you're
yeah. Please.
So maybe when you're ready, you can organize a FAPSS live operative workshop also sometime in future. Is it possible?
Yeah,
You
but
can share the link with.
live workshop only with this technology will allow me only 6 persons to join. But I have got this, what I am wearing now, this is different. This is, I can join with this into the Zoom. So I can share it to 100 people. My subscription with the Zoom allows me to share to up to 100 people. So I can do that. Yes.
Yeah,
If
so
you,
maybe sometime you can plan that for us next year,
yeah, if you
2022.
ask, this is what I do every day. Whenever I do an operation, I ask my trainees to join if they can. I have got 12, 3, 4, 5, they join whenever they are free. So, but with the Zoom, I can allow 100 people. I have
So
got both
Professor,
technologies with me.
so Professor Jabrul, first of all, thank you very much for showing you this lovely new thing for us. And as Dr. Shilpa said, maybe it would be nice if you do 100 people can join, probably they can join us. So it would be nice for us. Thank you.
Thank you.
Thank you, Dr.
Thank you,
Nabila.
everyone.
Yes, thank you.
Okay,
Sir,
so here is the QR code. Kindly scan and give your feedbacks. That will help us improving the webinar and will be guiding us for future all the running of these webinars. And I'm again thankful to everyone and thank you so much.
Thank you.
And now Dr. Jafar, we can say good night.
Good night.
Thank you.
Thank you.
Thank
Bye.
you. Thank you.
Bye-bye.
Bye.
Hi, Shilpa.
লিভ করবো না বাবা।
I hope everyone has scanned the QR code and has started filling the feedback form.
Thank you, Shilpa, for inviting me for this one. It was nice to hear. I mean, people were so good stuff from different countries. I mean, बताओ, it was very good. और दूसरी बात बता रही ये जो नबिता, what is her name?
Nabila.
She was good, very good. And the institution, imagine an institution having 250 beds dedicated only for pediatric surgery. That's wonderful.
Thank you so much. I invite you all to please plan and do visit us, and you will love the Lahore and the heritage in the Lahore and the institution. You will love.
It's wonderful, really, wonderful, really.
Thank you.
I would love to welcome you sometime to Varanasi as well. We are doing.
I'll surely plan.
Laparoscopic pediatric surgery.
Thank you so much for the invitation. I'll surely plan. I have been to Delhi twice, but I'll definitely plan, inshallah, in future.
Varanasi is not too far away from Delhi either.
Okay. I will tie up with Shilpa and will definitely plan.
You know, Shilpa has been a product from Varanasi, and we would love to welcome you, both of you at Varanasi.
That's really great to listen.
Great.
And
Yes.
I will look forward for you to be sparing time regularly and to joining us in the future as well.
So, I mean, if I keep getting the link, I would love to do it.
We will surely be disseminating the information, and as it is 22nd February, so inshallah in the January we will again start approaching you all and will keep reminding and rather bothering you with our presence and requesting you to join.
Pleasure, it's pleasure. And it was eye-opening that how much good work you are doing.
Thank you so much. It's so heartening to listen to these encouraging remarks from a legend like you. Thank you so much. And I hope everyone has done the job. And I think if you are left with, and I'm thankful, I think Dr. Arshad is still with us. Dr. Arshad is Professor Dr. Mohammed Arshad is currently president of Association of Pediatric Surgeons of Pakistan, and he is executive member with me in FAPSS. Thank you, Dr. Arshad, for being with us, for giving your input, and thank you so much for sparing so much time, and you are still with us.
One thing from my side, I am Professor Kamrul. I am inviting you again in our international APSB Association of Paediatric Surgeons of Bangladesh Conference 24 in 15 to 17 February. I will officially invite you as I have an email of you all, and please join us. Hopefully, I will meet you. We will meet you all.
Inshallah, thank you so much for the invitation. And this is the only way we can progress, by moving together, by sharing our experiences, by exchanging knowledge and expertise. And this is the way, actually.
Yes.
Thank you. Okay.
Thank
Good night, everybody. Thank
Good
you
night.
so much. See you, inshallah, again. Thank you.